So, good evening, everyone. Myself, Dr. Sanyal Kumar, on behalf of the Academy of Pain Physiatrists, I warmly welcome you all to our 14th webinar being held on this very special occasion of 79th Independence Day. So, happy Independence Day to all. Today, we have the privilege of learning of a highly respected figure in the field of pain medicine, Dr. Tushar Munnoli. It is an interventional pain medicine specialist and the director of REGENIQUE Pain and Spine Orthobiologics, Bengaluru. He holds a fellowship in pain medicine and certified interventional pain sonologist from the World Institute of Pain, a highly prestigious certification for the pain specialist. Dr. Munoli was honored as one of the top pain specialists in India 2024 by Silicon India and received the Young Pain Physician Award at the Indian Pain Update Delhi 2024. His area of special interest regenerative medicine, joint denervation, and neuropathic pain. Dr. Munali also a part of professional memberships like Indian Society of Anesthesiologists, Indian Society of Study of Pain, and World Institute of Pain. He is currently a governing council member of the ISSP Karnataka chapter. I encourage all participants to stay engaged. Note your questions and write them in the chat box. We will have a short question and answer session toward the end of this session where Dr. Munoli will address them. So, without further delay, let's begin our journey into the understanding entrapment neuropathy more deeply. So, Dr. Munoli, over to you. You can start.
Thank you. Thank you, Sanyal, for a very nice introduction. And so, firstly, a very happy Independence Day to everyone. And thank you, IPP, for inviting me to speak on this webinar on peripheral nerve entrapment, which is a common and it's mostly underestimated condition with potential to cause significant disability. So, over the next few minutes, we will explore into the recent insights into its pathophysiology and how advances in imaging, particularly ultrasound, are helping us to make more accurate diagnosis. And then we'll also discuss about the approaches to managing these nerve entrapment disorders, achieving their own freedom. So, no disclosures as such. So most of the, all the patient images and videos are shared with the informed consent for academic purposes. And some of the images have obtained permission from the original authors to reproduce them in this presentation. So entrapment neuropathy, or it's also called as compressive neuropathy. It is a pressure-related or pressure-induced injury to a peripheral nerve in a segment of its course. And I mean, it's due to anatomic structure or pathologic processes. So Vale, he's a physician. He was a physician, and he described these anatomical structures or nerve constriction sites, which are called Vale points. And these points are where the nerve pierces the fascia, muscle, or aponeurosis. So you can think of the median nerve through the carpal tunnel or ulnar nerve through the Guyon's canal. And the other points, other sites are where the superficial nerve rests upon the resisting surface. So you can, think of ulnar nerve at cubital tunnel. And then the other sites are where the nerve branches. So sciatic nerve branching into common peroneal and tibial nerve, where the nerve terminates in the skin. So these are the endpoint nerves, such as cutaneous nerves, and these can also become inflamed due to localized trauma. So all these are, nerve constriction sites or valley points. And then we also have, pathologic processes like inflammation or edema of the adjacent structures, such as tendons and probably some scars from the surgery, and that kind of reduces the passageway to the nerve. And then there are also mechanical forces on the nerve, like labral cyst impinging on a suprascapular nerve. So all these can result in nerve compression. And there can be several systemic diseases like diabetes, thyroid, rheumatoid arthritis, and they also contribute directly or indirectly by affecting the structures around the nerves. So it is clear that we have both external and internal factors that play a role in etiology of these entrapment neuropathies. So this vulnerability of the nerve to the compression was, demonstrated by Bennett et al. And you can see a study here. And this is the most widely used animal model for studying the neuropathic pain. So what they did, these researchers, they placed ligatures 1 mm apart around the sciatic nerve of the rats. And the crucial part here is that they tie these ligatures just tight enough to cause problems. Not so tight that you can actually see the nerve being squeezed or cut off. So even if you see this light constriction that led to prominent and rapid morphological changes, leading to the hyperesthesia and allodynia in the rat. And as you can see in this picture, just 1 day after the ligatures were removed, and so this kind of provides a rationale that peripheral nerve may be more vulnerable to light compression also and entrapment effects, and it is capable of creating structural changes in the nerves, as causing the neuropathic pain. So even the light compression can cause the nerve entrapment neuropathy. So before discussing more about the pathophysiology, it is essential to understand the normal nerve structure. So peripheral nerves, as you can see in this picture, these are the bundle of nerve fibers, and each nerve fiber, myelinated or unmyelinated, it is surrounded by a connective tissue called endoneurium. Okay, and at endoneurium, this separates the axons from each other, basically electrically isolating the individual nerve, and bundles of the nerve fiber together form the fascicles. Okay, so these are fascicles, and which is surrounded by another connective tissue, which is the perineurium. And this perineurium forms the blood nerve barrier structure, and it kind of provides tensile strength and elasticity to tolerate the stretch. And these fascicles, they are held together by the epineurium. You can divide into outer and inner epineurium. And the epineurium basically is formed by collagen fibers, elastic fibers, and contains a lot of abundant fibroblast and structures. Scattered mast cells also. So these fibroblasts are kind of responsible for the fibrosis after the nerve injury, which can limit the mobility and further increase the additional risk for the nerve compression. And then adipose tissue, which acts as a shock absorber in that's a function of that. And what happens in diabetics is that adipose tissue is often reduced, and that is why this that explains basically the increased vulnerability of the compression injuries, mostly in the diabetic patients. And this is a very important slide. So now that you know the structure of the nerve, so there are few other important points that you should know. And the peripheral nerve, or the main trunk, it is supplied by the free nerves. So meaning the nerve has its own nerve supply, which is called nervi nervorum. And these nervi nervorum innervate and regulate the function and discharge of the main nerves. So this actually contributes to the maintenance and worsening of the neuropathic case in case of entrapments. And additionally, the main trunk also has its own blood supply called as vasa nervorum, and these are very small, blood vessels. They kind of supply nutrients to the main nerve, and also the veins which drain away the metabolites from this main nerve. So entrapment of the vasa nervorum would likely result in stasis and ischemia, and the potential accumulation of the toxins of the affected part of the nerve. And the main trunk has also its own lymph vessels. So, so basically the nerve has its own blood supply, nerve supply, and lymphatic drainage. So what happens when a chronic nerve compression, there is a physiological cascade starting with, the microvascular damage in the nerve, and that leads to the, I think I can see some red marks here on the screen. Okay, fine. So this causes the stasis and ischemia, resulting in the buildup of toxic metabolites. And since there is a breach in blood nerve barrier, okay, there is subsequent epidural, endoneural, and intrafascicular edema. So that kind of causes I mean, microcompartment syndrome. So that is the first manifestation of the compressive neuropathy. And prolonged or repetitive compression, this induces the epidural neuroinflammation, okay, which is mostly in the outer layer of the epineurium. And this inflammation may sensitize the nervi nervorum, the basically the nerve of the nerve, okay, and it may induce the spontaneous activity and resulting in the hypersensitivity. Also, the inflammatory cells, the T lymphocytes and macrophages, they also activate the fibroblasts which are there in the epineurium, and that leads to the thickening of the nerve, and that restricts the nerve gliding. Okay, so the combination of all these factors, they lead to the axonal demyelination and degeneration. So that results in slowing in the nerve conduction in the chronic nerve. So that is, this is how, this is the pathophysiology of the entrapment neuropathy. So we can classify the peripheral nerve injuries, and it is important. There is Sutton and Sunderland classification. Okay, so the first, I mean, this is an intact peripheral nerve. You can see the myelin, axons, and all the connective tissue layers here. In the first degree nerve injury or neuropraxia, the myelin sheath is damaged, but not the axon. So this type of injury typically occurs in the radial nerve at spiral groove. I mean, we call it Saturday night palsy. And when sometimes we see, I mean, we said crossed leg. So, the peroneal nerve, the superficial peroneal nerve is kind of getting compressed. So these are the examples of the neuropraxia. And then there is second degree nerve injury or axonotomesis, where, the the damage extends to the axons. Okay, so you can see the axon is damaged, but the connective tissue layers, the epineurium and all perineurium, they are intact. Whereas in grade 3, axon and endoneurium are damaged, perineurium is intact, and grade 4, the perineurium is also disrupted. And grade 5, there is loss of continuity of the entire trunk. So that is neurotomesis here. So the common peripheral, these are the common peripheral nerve entrapments. Mostly we deal with the carpal tunnel syndrome and, cubital tunnel, ulnar nerve. So these are the common peripheral nerve entrapments. We'll not, kind of discuss them in separate thing. We'll just discuss in general. So there are some clinical features that should be known and sometimes mostly predictable, and that actually depends on which nerve is affected, who is the victim here. For example, if the median nerve, is it the median nerve which is causing the carpal tunnel syndrome, or the ulnar nerve at the elbow, the peroneal nerve at the fibular head. So we figure this out through the pattern of the symptoms, kind of tingling in specific fingers, weakness in certain muscles. So we can actually see, I mean, know where which nerve is affected and where along its nerve is affected. So a nerve can get impinged at multiple spots, like median nerve can get compressed at the wrist carpal tunnel, or further up in the at the pronator teres, similar to carpal tunnel, right? But pronation and palmar numbness, so these kind of are affected. And how long and how severely the nerve is affected. So how much damage was done to the nerve? Is it the temporary irritation or chronic compression? That you can see when you ask the patient about if it is numbness or muscle wasting. So these kind of determines if we try, I mean, helps in to determine treatments or interventions or surgeries. So to keep it simple, nerve do basically three things. There is pain fibers, muscle fibers, and sensory fibers, and they can have associated dysfunction in case of entrapment. So patients can present with pain, tingling, numbness, hyperalgesia, allodynia, decreased sensation, and involved muscle weakness, often exacerbated with certain movements. So you need to ask about them when you take the history and do the physical examination. Uh, and so nerve entrapment can be diagnosed on the basis of signs and symptoms alone most of the times. Okay, so you don't need other investigation. So you just ask the history of the patient, take the history of the patient. Probably you will have the diagnosis. It is important to know that peripheral neuropathy and peripheral nerve entrapment sometimes can present in similar fashion, and that's why some authors recommend, basic evaluation to rule out the peripheral neuropathy. So this includes thyroid function, fasting, blood glucose, vitamin B12, folate, nerve conduction studies, etc., etc. So most of the, but like I said, history and physical examination mostly supports the diagnosis for many patients, and the other tests are, most of the times not necessary. So electrophysiology serves an extension of a neurological examination, and for evaluating, for evaluating all the variety of focal and generalized neuromuscular conditions. So it can tell us about which nerve is affected, location of the nerve injury, is it motor or sensory or both is affected, if it's an axonal or demyelinating neuropathy, if there is an evidence of reinnervation, if it's neurogenic or at the neuromuscular junction, or is it muscle related, and even about the radiculopathy. I'm not going too much in detail about the nerve conduction studies, but some basic, aspects. So actually, nerve conduction study is a component of the electrodiagnostic testing. Okay, so this nerve conduction study reflects the function of axons, okay, and surrounding myelins. Okay, and we can actually get two types of responses. One is the SNAP, sensory action nerve potential, okay, and the other is the CMAP. So SNAP is for the sensory nerves, and I mean they tell about the sensory nerve pathways. Okay, and for sensory nerve, we stimulate and record along the same nerve, finger to wrist, and some we get some metrics like onset latency here. So basically, that is time from the stimulus to the first response. First response. So if it is prolonged, you can think of demyelination. Okay, and this is called amplitude. So amplitude, it represents a number of axons that are taking part in the generation of an action potential. So if this is reduced, you can think of axonal loss. And then you also have conduction velocity, the speed of the signal travel. So I mean that is basically how fast an electrical impulse travels along the sensory nerve. So again, if it is slow, the conduction velocity is slow. You can think of demyelination. And for motor testing, we stimulate and record from the muscle it controls. Okay, and here also we have distal latency, amplitude, and conduction velocity. So basically the nerve conduction study is like a speed test for the nerves, revealing where and why the signals break down. And we have to combine this with EMG most of the times, and EMG is another component of the electrodiagnostic studies, and together they can actually pinpoint where the problem is in, if it's in the nerve or in the muscle, or is there any connection in between them. So again, just remember, these are the fibrillation potentials here, the tiny spontaneous electrical discharges, and positive sharp waves, initial sharp down peak and then slow return. Okay, so these are basically the crisis signal of the muscle. So meaning the muscle has lost its nerve supply, and then there can be signs of reinnervation, and this will display as signs of electrical instability manifesting nasal potentials. So most of the times the entrapment neuropathies are the grade 1 and grade 2 nerve injuries, and you can see these findings here. So myelin in grade 1, myelin sheath is damaged, and thus the nerve conduction study will show reduction in conduction velocity, and the amplitude is normal because the all the axon, the axons are intact. So whereas in grade 2 the axons are involved, and that's why you can see there will be mild to moderate decrease in amplitude. whereas in grade 3 it will be severely decreased amplitude. Neurography is another tool for diagnosis, but it is often not the first choice. Yeah, it has its own limitations, and it's particularly useful in assessment of deeper structures, that are beyond the range of high resolution ultrasound. So MR neurography helps to identify the perineural structures that are impinging on the nerve, and then abnormalities within the nerve itself, such as there will be focal enlargement, and fascicular pattern might be altered. So all this you can actually look for in MR neurography. And in addition, it can identify if it's an acute or chronic changes of neuropathy. You can identify through the MR neurography. Ultrasound now, it's in fact considered nowadays, the first imaging modality for assessing the peripheral nerve. Thanks to the latest generation high resolution high frequency transducers and technology. And we all know the advantages: low cost, have great high resolution, ability to image the entire limb in short time, and you can actually have the panoramic view of the nerve. We can also do a dynamic assessment of the several part of the nerve. We can assess dynamic movements. So there are a lot of positive attributes of the sonography, and also it is well tolerated by patients. Of course, no contraindications. So I think ultrasound must be our first imaging modality to assess the peripheral nerve entrapment. So before we move on to how to diagnose the nerve entrapment, there are basic principles of the nerve scanning, which will help us to get the optimal images. Okay, so it's needless to say that we use high frequency transducer, linear transducer of at least 10 megahertz, and the transducer is placed perpendicular to the nerve for accuracy and position accordingly. For example, the median nerve, it actually dives deep once it leaves the carpal tunnel. So the probe is kind of tilted according to it, and it will be perpendicular to the nerve. So these subtle change, things are very important, to get the consistent measurement of the nerve. And sorry. So scanning the nerve is something like sniper video game. You have to lock the target and you have to follow it. And so using a long pathway of coupling gel along the direction of the scanning can assist with the rapid evaluation. So these are the small tips and tricks basically. And then correctly you identify the nerve tissue. So peripheral nerve have the characteristic honeycomb appearance in the short axis, and at long axis ultrasound scan it appears as a bundle of straw. So you have to identify the nerve in both the long and short axis. Okay. And this honeycomb pattern is because of the hypoechoic fascicles, around in the short axis, and it is, you can see this dark hypoechoic here. So it is an elongated parallel hypoechoic fascicles in the long axis. And then, the fascicles are surrounded by the perineum. That's why you have the hyperechoic, connective tissue here. And on the right, you see the multiple hyperechoic lines are intervening the hypoechoic fascicles. So this is how you identify the perineural structures also. And the outermost connective tissue is the epineurium. And this also you should know how to identify, because it's very important when it comes to the measurement of the nerve. And of course you should know the surrounding anatomy. You should know how to differentiate it from the tendons and the muscles, blood vessels, and you can identify easily depending on the pattern of the tissue. And we must also give attention to the pressure on the transducer, especially when you do the nerve measurement. So epineurium, as we discussed, is kind of relatively flexible, and it results in shape change, while the perineurium is inflexible. Okay, perineurium basically covers the fascicles. So perineurium is inflexible. Therefore, fascicles, they do not deform with routine pressure, but it will kind of redistribute inside the shape altered epineurium. So thus, if there is a focal change in the nerve shape, despite only light pressure, or if there are alterations in the shape of the fascicles, then this should be considered as an abnormality. Then it is important to know how to measure the nerve diameter. So it is crucial that the transducer is placed perpendicular to the nerve, and for accurately measuring the cross sectional area. Okay, so if it is slightly cross, also you will get false results. And the measurement should be performed at the inner border of the echogenic epineurium. Okay, not the outer border. It's mostly in the inner border for the consistency. That's because the outer portion of the epineurium can be sometimes more difficult to distinguish from the surrounding tissue. Okay, and manual tracing is also preferred, compared to the automated eclipse. So the ultrasound machines has automated eclipse. So rather than the going for the automated eclipse, manual tracing is a better way to measure the cross sectional area. So now coming to the sonographic parameters of the nerve entrapment, the first parameter is the nerve shape. So the hallmark of the nerve entrapment, typically presents with swelling proximal to the entrapment site, right? And notching will be at the level of the compression. So this is the hallmark of the nerve entrapment. So this is the image of the median nerve at wrist long axis and short axis. So here you can see flattening of the nerve at the compression point. So this is basically the notch sign. And then there is swelling proximal to the entrapment site. So together with notching, this kind of forms a mouse tail sign. Okay, so this is one of the hallmark of the nerve entrapment. Then the next parameter is the nerve ecotexture. So normally you have a honeycomb pattern appearance, right? But in the nerve entrapment, the fascicles are tightly packed, swollen fascicles because of edema, vasoconstriction, and fibrosis. There is a reduced ecogenicity, and that's how the honeycomb pattern is. There is destruction of the characteristic honeycomb pattern. So this you have to see in the short axis only. And not only the size of the nerve, but sometimes the pattern of the fascicles also is important to see if you're dealing with abnormal nerve, right? So in this one you can see, this is the sciatic nerve, and you can see here the common peroneal nerve, the fascicles are swollen. Okay, so usually more than 2 mm, less than 2 mm is normal, more than 2 mm is abnormal. So as you can see, as it divides, you can see the common, the common peroneal nerve actually is the fascicles are swollen. Then another important parameter is the nerve caliber, because nerve swelling is the most helpful diagnostic marker, right? So cross-sectional area, I think we've just discussed how to track and measure the cross-sectional area. Then there is something called as swelling ratio, which is defined as a difference between the cross-sectional area at the affected site and at the unaffected proximal site of the same nerve. Okay, so that gives you the swelling ratio. And another measurement tool is the flattening ratio. So that is calculated by dividing the largest diameter of the nerve by its smallest diameter. So A divided by B. So normal nerve is usually round, and the flattening ratio is around 1 to 1.5. And if it's a compressed nerve, it is mostly elliptical, and the flattening ratio kind of increases. So in carpal tunnel syndrome, the flattening ratio of more than it will be more than 3. So these are the sonographic parameters references for some of the specific mononeuropathies, which are summarized in this table. And usually for the carpal tunnel syndrome, the cross-sectional area of 10 to 12 is borderline. More than 12 is, suggestive of carpal tunnel. And flattening ratio also, I think we discussed. More than 3 is suggestive of carpal tunnel syndrome. The next parameter is the nerve mobility. Some nerves are known to be mobile when the compression, when the corresponding joint moves in flexion and extension. So in this video, you can see the median nerve moves within the carpal tunnel when the wrist and the fingers perform active flexion, right? And here you can see the mobility is kind of partial or absent. So that's because of the nerve are possible. So you should also look for the nerve mobility. And the another parameter is the intraneural vascularity. So that is also, I mean, it's actually area of a developing interest still. Usually, no internal blood flow is seen with color Doppler in normal nerves, but compressive or inflammatory neuropathy causes vascular congestion, and with that, there will be increase in the intraneural blood flow also. So you can assess that by placing the power Doppler over the nerve. Okay, so it's not very accurate, but yeah, this is kind of probably more studies will come on this. And in chronic entrapments, the distal innervated muscle ecotexture also, changes. So the picture on the right here, you can see the tibialis anterior muscle. It's like very bright white, right? Dense, and then, the muscle architecture is not there because of the more reflections in the pathological muscles. And the muscle also is thinner, so it's atrophied. So this is what it looks like when the muscle is denervated. So in summary, when assessing the nerve entrapment or ultrasound, we look for the nerve shape, ecotexture, caliber, mobility, intraneural vascularity. So these parameters together, help us to confirm the diagnosis and also to assess the severity of the entrapment. Coming to the management, so clinical guidelines suggest a course of conservative treatments before more invasive options are considered, right? So, physical therapy, physiotherapy, immobilization, activity modification. So these are the conservative treatments, you can do, and pharmacological treatment. So there is limited literature specifically on pharmacological management of nerve entrapment syndrome, but in practice, we treat it much like other neuropathic syndromes using the systemic medications either alone or in combination. So we can do monotherapy also, and the main drug classes that include are the NSAIDs, opioids, anticonvulsants, and antidepressants. And these are all the medications, dosage, and maximum dose we can use. So the choice of the medication actually depends on the patient's safety, comorbidities, and compliance. So you can go through this list. And topical patches like lidocaine and capsaicin can have a role in managing pain from peripheral nerve entrapment, but they're more of an adjunct, rather than primary treatment, and it is more useful for the focal or the superficial nerve entrapments like postsurgical scars or superficial peroneal nerve entrapment or cutaneous branch involvement. There's no much role of IV infusion therapy in nerve disorders. And coming to the interventions, so injections, they have a unique role in managing the peripheral nerve entrapments. So one approach that's gained attention is the nerve hydrodissection, where we separate, the nerve from the surrounding tissue, usually the fascia, by injecting the fluid under the mostly under the ultrasound guidance. So it's important to not to confuse with the hydrodilatation, hydrodistension, or perineural nerve, perineural injection therapy. So all these are different terms. So it's not related to the nerve hydrodissection. So I just told you that hydrodissection is a procedure in which the injected is delivered perineurally to mechanically release and decompress the entrapped nerves. So evidence actually suggests that hydrodissection alone can be highly beneficial. So we aren't talking about the injected, but just the hydrodissection. As you can see, the study by Wu and his colleagues, they comparing the hydrodissection with 5 ml of normal saline to a simple subcutaneous normal saline injection above the carpal tunnel. So the patients who received hydrodissection, they showed significant improvement in function, function status and symptom severity and reduction in median nerve edema which actually lasted up to 6 months. So hydrodissection kind of lightly decompresses the vasa nervorum, the nerve supply. I mean the blood supply to the nerve, the nervi nervorum, the tiny nerves that innervate the nerve sheath. So that is kind of mechanically released, and which leads to increased blood flow, improving mobility, and relieves the mechanical pressure, also ultimately restoring the nerve function. So there are various injectors which are available to choose from. Corticosteroids has been used for many years, but it needs careful consideration and judicious use. Not only there is a risk of skin depigmentation or fatty atrophy, but sometimes these can cause suppression of the hypothalamic pituitary axis, suppression. Then we have saline, lidocaine, hyaluronidase, hyaluronic acid, dextrose, platelet lysis. So all these have been kind of used and studied. So let us see what is good. So but before that, like, it's important to know that the carpal tunnel syndrome is most extensively studied clinical condition that is treated with the hydrodissection of the nerve. So that gives us confidence to use the injecteds in other nerve entrapments as well, because the most of the studies are on the carpal tunnel itself, carpal tunnel syndrome. So again, this is a study by Wu et al. So in this randomized trial, hydrodissection with 5% dextrose outperformed the median nerve, the saline for the median nerve entrapment with better symptom relief and functional improvement. So 5% dextrose is better compared to saline. And then there is another study by the same author, which compares the 5% dextrose with the steroid injection. So remarkably, dextrose here was more effective compared to steroid injection. So we can actually avoid the steroid related side effects. Then there is a study by Shen et al., which revealed a single hydrodissection with PRP. So basically, when I'm saying PRP, it's basically platelet lysate. So most of the studies have used platelet lysate, and that was more effective in reducing the cross-sectional area of median nerve compared to the 5% dextrose. So basically, platelet lysate and 5% dextrose outperform the hydrodissection with the steroid and saline. So the actual mechanism of how PRP or lysate helps in the recovery is not fully understood, and it can be multifactorial. But it is hypothesized that a lot of these growth factors help in angiogenesis, neurogenesis, and nerve regeneration. Um, by its the direct effects of the growth factor. And dextrose, 5% dextrose is becoming the solution of choice for nerve hydrodissection. As it, there is a lot of good evidence. It's more cheaper, safe, no side effects, and can be used in large volumes. So if you want to do a platelet lysate, maybe you will just get minimal volume, and we'll discuss about the volume also. So 5% dextrose can be used in large volumes also. And to understand why 5% dextrose is effective in nerve hydrodissection, we need to look at the action of the TRPV ion channel. So previously, this TRPV was also called as capsaicin receptor. So these receptors, they are found mainly on the nociceptive neurons of the peripheral nervous system. And these are, TRP1 is highly sensitive to mechanical injuries, including the nerve entrapment. So when the nerve is compressed or injured, the TRPV1 channels, they are activated, and then there is influx of the calcium and sodium into the cells. So the sodium influx causes depolarization of the membrane potential, and that causes pain, right? And then calcium influx, they trigger the release of neuropeptides, the substance P and CGRP from these microvesicles. And these are basically pro-inflammatory mediators of the sensory nerve, causing the nerve changes in the sensory nerve function. Okay, so this neurogenic inflammation leads to chronic pain, swelling, and further nerve dysfunction. So what 5% dextrose does it downregulates the TRPV1 activity, effectively muting its this overactive pain pathway. So it reduces the sodium influx, and thus there is less depolarization, less pain signaling, and then it blocks calcium and less substance P and CGRP release. So obviously less neurogenic inflammation. So it has antagonizing effect. Dextrose 5 has the antagonizing effect on the TRPV one receptor, I mean channels. Also, a compressed nerve exists in a state of local hypoglycemia. So I mean, the nerves are literally starved for the glucose. So this creates, cascade of dysfunction. So without glucose, nerve can't produce, ATP. So the ATP dependent sodium potassium pumps, they actually shut down, causing again the sodium to build up inside the cells, and again there is membrane depolarization triggering the abnormal neuronal firing. So when we do dextrose, 5% dextrose injection, the the potassium channel, they have the receptors for this dextrose. Okay, so the dextrose binds to the ATP sensitive potassium channels, and the channels that were closed due to hypoglycemia or glycopenia, this binding force allows the potassium to exit the cell, and with potassium flowing out, the membrane hyperpolarizes, and this is how the fewer action potentials are there, and there is less pain signal. So these are the main mechanism of action of how the dextrose 5% dextrose works on the to relieve the pressure, I mean the symptoms of the nerve entrapment. And there should also be basic principle you should know about how to do the nerve hydrodissection. So the volume of the hydrodissection remains a highly contested topic, with most of the studies showing between 1 to 10 ml. Some argue that the use of increased volume may also result in better distribution of therapeutic properties of various injectates. So you can use between 5 ml to 30 ml, and we will see all this how to do it. Injection interval mostly, again, that's also there is no consensus in the literature about the timing. So usually 1 to 4 weekly is what we do. And talking about the technique, there are 2 or 3 techniques. So technique one is usually for the small diameter nerves, a smaller length of the nerve entrapment, right? So for that we use in plane approach. The needle is perpendicular to the long axis of the nerve. Okay, and so this is what we do commonly for all the nerve blocks. But here the important thing is the bevel position actually matters, and it indirectly impacts the needle direction, as you can see in the this in this picture. So the tracking of the needle depends on the bevel of the needle. And so ideally the needle first approaches the inferior surface of the nerve with the needle position, bevel, I mean the bevel positioned up, and then we can inject. And when approaching from the superior aspect of the nerve, the needle bevel is positioned down and injected. And the direction of the jet helps to peel the nerve from the surrounding retinaculum and the connective tissue. Okay, so this is the video. You can see this is the bevel up here. So the most common location for ulnar nerve entrapment are at the cubital tunnel with flexor carpi ulnaris, and at the level of the arcade of supracondylar region. So this is at the supracondylar region. The probe is transverse, and the needle is approaching in plane from medial to lateral. I mean from the posterior aspect when we are doing the ulnar nerve hydrodissection. And when you have medium large diameter nerves or larger length of the nerve is entrapped, you can use this technique. Okay, this is similar to technique one which I described, but in this case you have to pivot the probe and the needle from proximal and distal parts of the nerve within the same needle entry. Okay, so you can use the same needle entry. So you just have to pivot the probe to this direction, proximal or and distal. So this is how you can actually cover the larger area of the nerve entrapment. So this is technique two, and the another technique is the probe is first perpendicular to the long axis of the nerve, and the needle is parallel to the nerve, and this is a basically out of plane technique. Okay, so hydrodissection of the nerve from surrounding tissues. You can see here. I think I'll just play this video. Yeah. So this is the nerve here. You can see, and the needle is coming out of plane, and visualize the anechoic fluid surrounding the nerve. Okay, and at this point you turn the probe in plane towards the nerve, and the needle tip is guided back to the top of the nerve, and the fluid is injected above it, so with the the bevel position down. Okay, so again you can see the injected being the injection fluid should be visualized here. Okay, tracking, and that should be above and below the nerve as well. Okay, so generally method 2 for hydrodissection can separate a comparatively longer length of the nerves from the surrounding soft tissues. This is kind of challenging, but if you can do it, that is also better. So this can also help to do a longer length of the nerve. Potential complications, mostly nerve injury, mostly direct needle trauma, or even the excessive fluid can compress the nerve itself, and of course you avoid the internal and intraneural injection. Infection chances are minimal, but yeah, you have to take all the precautions. So to summarize, peripheral nerve entrapment can cause wider number of clinical presentation. You have to identify something called as double crush syndrome. Compression at two or more locations along the course of a peripheral nerve. So that can also exist. So you have to identify that. And multiple tools are available to aid in the diagnosis of the peripheral nerve entrapment. And the choice of the technique depends on the structure to be studied. And USG, I think, can be considered as the first choice. And nerve hydrodissection is a useful tool, obviously very rewarding when you do it with the ultrasound guidance. And dextrose 5, I think we have seen many studies. It is an ideal injected. Thank you.
Thank you, Dr. Tushar, for your valuable and great insight on entrapment neuropathy. I think our participants get benefited from this webinar. And so we let's start with our Q&A, question and answer session. There are a few questions in the chat box. So okay, we can take one by one.
Yeah, yeah, sure.
Yeah, so the first question is that can you please repeat again how to identify nerve on USG and differentiate nerve from the surrounding structures?
So basically, I think if you have seen my presentation, so basically nerve is kind of, honeycomb patterns. You have vesicles in the nerve. So that is mostly hypoechoic. So you will have hypoechoic pattern and then surrounded by hyperechoic. And then you have an epineurium, which is again showing the hyperechoic. So basically it's a honeycomb structure. And mostly you have to differentiate it from the tendons, because that's where the confusion arises. Okay, so there are different ways to identify or differentiate it from the tendon and nerve. So basically, tendon is mostly brush-like. The pattern is brush-like, intercalated. Okay, and you can actually see them. I mean, when you're doing a carpal tunnel, scanning of the carpal tunnel, so you can identify or differentiate it through the movements also. So, like I discussed, the nerve is mobile, like it actually jumps on the tendons. So that's how you can actually differentiate. And if it's obviously, I mean, when you have, if it's a swollen nerve, you can easily identify it. But yeah, like, there are some tips and tricks. I think I mentioned those.
Thank you. Another question, sir, which is the first choice between glucocorticoids versus 5% dextrose versus PRP in carpal tunnel syndrome, and what are the criteria to choose them injected?
So, if it's a moderate carpal tunnel syndrome, studies have shown that platelet lysate is better. So, when we say that it is, I mean, PRP, I think most of the studies, if you read the methodology and everything, it is mostly the platelet lysate. That means I mean, the PRP is basically lysed, or the platelets are lysed, and the growth factors are released, and the cell membranes and the other debris are removed. So that is what is platelet lysate. So most of the studies actually they use platelet lysate, and studies show that it is better when, I mean, when there is a moderate carpal tunnel syndrome, platelet lysate is a better option. But there is no studies. I mean, in India we have growth factor concentrate GFC, but we don't have any studies, of using growth factor concentrate in nerve entrapments. So I mean, ideally for us, I think in clinical practice, dextrose, I mean D5W, dextrose 5%, I think works better.
Yes, sir. So, another question: can we use higher concentration of dextrose as well in
Uh,
entrapment neuropathy?
yeah, very good question. So basically, higher concentration, that means you're doing a prolotherapy, right? So any concentration of more than 5%, it's basically pro-inflammatory. So we don't want that. So if you see the 5% dextrose, actually they kind of act on the TRPV1 channels. If it is more than 5%, I don't think. I mean. The literature says there is only 5% dextrose, so that is perineural hydrodissection. We use 5% dextrose. More concentration of dextrose is basically pro-inflammatory, so it's kind of irritant, so we don't use it.
Okay. The another question: have you worked with hyperacute serum? It is similar to lysate.
Hyperacute serum. Again, there are a lot of different terms. How you in India, I think there is one of the company Recuse. So they have designed this hyperacute serum. It's actually similar to growth factor concentrate, I would say. See, basically in lysate, what they do is there will be a filter. So the filter will remove all the debris. Okay, so debris in the sense there will be cell membranes and other structures of the cell which are not useful. So only pure growth factors are basically used in platelet lysate. So we don't have the filter, like it's a very with micrometer filters which are not available here. Like, I mean, at least in the clinical practice. So platelet lysate and GFC are a little different.
So another question is mm, one minute. Platelet lysate. I think you already give this answer. Platelet lysate means GFC. Can you brief how it is? How is it prepared?
Yeah, I mean, yeah, that's what, like, I mean, there are no studies of using GFC for using as an injected for nerve entrapment syndrome, so it's very difficult to comment. And so ideally, I use 5% dextrose in all the cases. You
Another
cannot
question:
use
what?
PRP because it has leukocytes, and again, a lot of again, controversies there. So ideally, platelet. I mean, when studies actually mention PRP, but if you read the methodology, it's actually platelet lysate is what is there.
So another question taken from the chat box: what is the exact volume of 5% dextrose in short axis and long axis injection for median nerve entrapment?
Yeah, so volume. So basically, if you want to do a longer, length of nerve entrapment release or hydrodissection, you can use a volume up to 30 ml. Okay, so you're just using, I mean, doing it in one particular scan or one particular, short axis. Then probably up to 10 ml is what I use. So basically,
Uh,
you should do a hydrodissection of the nerve. Basically, when there is mechanical compression, the nerve is flattened. Okay, and as you start to do hydrodissection, you will see the nerve shape actually starts to change, and that can also be one of the sign that your volume is kind of sufficient now.
yes. So another question, sir, when to glucocorticoid injection given in CTS conditions, carpal tunnel syndrome conditions, when we
So
give
steroids,
glucocorticoids.
steroids, I mean, I have not used steroids in carpal tunnel syndrome, but I know, I mean, neurologists, they do inject steroids. Uh, I don't have much experience, but yeah, like because of the side effects, I think probably you avoid them.
Okay. Another question है, but it's a basically it's a market values question. Do we get dextrose 5% easily in market? I have difficulty
Yeah,
in
5D
getting
is
it.
available. 5D glucose, I mean, 5D is available in the
Yes,
market. If you
yeah.
don't have
Mm.
25D, you can dilute it. Take 1 ml and
Yes.
dilute it to 5
Mm.
ml.
Mm. Uh, Another question is similar to that, and can we dilute 25D to make it 5D, and with what like saline or distilled water?
Yeah, good question. I think you have to dilute it with normal saline. Okay, so don't use distilled water. Use normal saline to dilute the if you're using 25% dextrose.
Okay. Which company makes platelet lysate, please?
Platelet lysate, I think, see, it's not about the company. It's like, it's about the filter. So those filters, I think, they're only in the hematology labs where they use to separate all the, I mean, the cells and all. So commercial available, none of them have still, they don't have the filter.
Yeah. So I think all the question we have taken from the chat box, and thank you, Dr. Tushar, once again for your valuable presentation. And I'm very much appreciate your presentation. You started from the basics like basic anatomy of the nerve and how the pathophysiology get this entrapment into the sign and symptoms of the patient. Then you go with the uh, ultrasound, how to identify the structure, nerve structure in the ultrasound, and how you get the pathological condition in the ultrasound imaging. So before we ending, there is a few questions from my end. What are the biggest research gap in the area that young clinician and researchers should focus on?
So, I mean, you're talking about the research aspect.
Yes, biggest research gap. Yes, research gaps.
Yeah, so again, I mean, it's mostly the ultrasonic parameters. If you have seen, I mean, there are studies, where you say carpal tunnel. If it is more than 12 mm, it's suggestive of carpal tunnel. If it is more than 14 mm, it's suggestive of carpal tunnel. So basically, it
Yeah.
all depends on the geographic location also. How tall the person is, how obese the person is. So there are certain discrepancies there. And in coming to the management aspect, yeah, I mean, like we just so many questions about PRP. So there is no standardization of PRP, the definition of PRP. People call, I mean, hyperacute serum, growth factor concentrate, platelet lysate, platelet releasate. So there are different terms. So I think we have to kind of focus on those aspects as well. But yeah, like we have actually good studies showing the effect of the 5% dextrose. And I think in one of my, I mean, most of my slides, if you must have seen, there is references of Dr. Stanley Lamb, his article. So I think you have to read it, like, maybe you have to read it 2, 3 times to understand, each and every point is very nicely mentioned. So I think everyone should read that article.
Okay. Thank you, sir. Thank you. And so I think no question in the chat box, and Anyone have any query about this entrapment neuropathy? Uh, Issued the article or the title, sir? Oh, this is the not the okay. So, uh, thank you. Thank you so much, Dr. Tushar, once again, from the behalf of our Academy of Pain Physiatrists. And so now we can wrap up the session. Okay, sir. Thank
Thank
you.
you all once again, and thank you, Debashish, yeah, for inviting
Yeah.
me.
Sir, one more question I think come. Can
Yeah.
5D be used in CRPS?
So, CRPS, the pathophysiology is different.
Yes.
But yes, I mean, CRPS, if you see, many times it happens that uh, uh, peripheral nerve entrapment is misdiagnosed as, the
Yes.
CRPS is misdiagnosed, and they say that, CRPS is kind of, it might be peripheral nerve entrapment basically. So you have to kind of diagnose that first. You have a lot of criteria to diagnose CRPS. And then some people do use hydrodissection, but only if it is because of the nail or because of the scar tissue. In that cases you can do it, but
Okay.
not the first choice. Yeah.
Yes. Okay. So, thank you so much, sir. And uh, thank you from the behalf of Academy of Pain Physiatry for accepting our invitation for this webinar. And now we wrap up the session. Okay. Thank you, sir. Again, good
Thank you.
night to all. Good night, Dr.
Good
Sir.
night.